Welcome to Impact Education's Payer Talk CE program, Bridging the Gaps, Improving Access and Timely Diagnosis for Retinal Diseases. My name is Steve Calusi. I am the Principal Consultant with Calusi Consulting, and I'm very excited to be your host for today's podcast. Today's program is jointly provided by Medical Education Resources, Inc. and Impact Education, LLC, and it's designated for 0.5 contact hours of continuing education credit. This activity is supported by an independent educational grant from Regeneron, and we'd like to thank them for their support. At the conclusion of today's program, you'll be able to complete an evaluation which must be submitted to receive credit. Click Complete Evaluation in the navigation within the activity, and once you complete your evaluation, you must click Claim Credit to download your certificate, or for pharmacists, submit your credit to CPE Monitor. I'm pleased to be joined today by Dr. Farina Ali and Julie Gritzmacher. I'll look to both of you to give a brief introduction. Dr. Ali, we'll start with you.
Thanks, Steve. Great to be here today. I'm a retina specialist in practice in Westchester, New York at Westchester Medical Center and faculty at New York Medical College.
Fantastic. Thanks so much. How about you, Julie?
And my name is Julie Gritzmacher. I'm the Senior Director of Patient Advocacy and Population Health at Prevent Blindness.
Excellent. Thank you both so much. And we're very excited to have you both join us today. And I think it's the best use of our time if we just jump right in. And so I'd like to just start by highlighting that there is a recent publication that's now available for download with today's webcast that sheds some light on how healthcare providers, patients, and payers view current strategies and remaining gaps in preventing and treating vision loss due to diabetic retinopathy, diabetic macular edema, and age-related macular degeneration. So, Julie, I'm going to start with you. Given the scale of DR, DME, and AMD in the US, how does the epidemiology of these diseases influence what you see in the patient journey?
Yes, so the numbers explain why this is such a public health issue. In the US, diabetic retinopathy affects nearly 10 million people, and about 1.8 million of those have vision-threatening disease. So globally, over 100 million adults are living with diabetic retinopathy, and that number is expected to rise significantly by 2045. With AMD, we're talking about roughly 20 million Americans and nearly 200 million people worldwide. The prevalence increases sharply with age, and late-stage diseases become much more common in older populations. What makes this especially challenging is that both conditions can progress before patients recognize symptoms. So despite the high prevalence, patients often enter care later than optimal, and the epidemiology, large at-risk populations combined with silent early progression, means that the patient journey is highly dependent on effective screening and coordinated referral systems.
Yeah, that's so interesting, and I think it's really important to highlight the significance of these diseases that are impacting older populations as our population just naturally gets older, throughout the years here. I think this is going to become even greater a problem than it already is. And so, Dr. Ali, where does the patient journey most commonly break down? When we're thinking about it from the perspective of from symptom onset all the way through ongoing treatment, where do the breakdowns happen for individuals with DR, DME, and AMD?
So those are great questions, Steve. And when we look to the data, we really see that breakdowns occur at multiple stages. So first would be detection. Many patients do present late, although with current imaging technologies, patients in current day practice are presenting earlier than they ever have, but we still do see delayed presentations because screening either didn't occur, so that imaging didn't happen, or symptoms were not correctly understood. And in fact, patients frequently do report misinterpreting early vision changes or just assuming that their vision is declining as they get older, which we know is not, normal physiology. Secondly, we think about access and referral delays. So payers and providers both have identified limited screening integration and specialist access as barriers. We do know that, as you spoke of earlier, with an aging population, we do have a very significant patient care burden and wait times to access retina specialists ophthalmology, optometry can be quite long, and nearly half of payer respondents indicated that current quality measures fail to adequately capture high-risk populations, so particularly patients with AMD or older adults without diabetes. And then third, we think about adherence over time. So the literature cites, in the report shows that up to 50% of patients discontinue anti-VEGF treatment within 24 months. We do know that this is meant to be a chronic treatment, and for many patients, they're receiving it over years and years and years or the extent of their lifetime. And so discontinuation at about 24 months really changes the prognosis for patients. And survey responses reinforced also that financial burden, transportation barriers, and frequent injection schedules, that is the treatment burden, do contribute to drop off. So there isn't really a clean breakdown at necessarily one single point. There is cumulative friction across detection, access, and persistence, meaning continuing care.
Wow, there was a lot to unpack there. Thank you so much for those insights. I think one of the very early things that you said is that just reduced vision over time as patients age. That's not normal physiology. That's I think a very common misconception, very similar to how older patients who are in pain just assume that when you get older you should be in pain, right? Like this is just going to be a normal process as you get older. So this is a really important consideration that the patients should be aware of that.
Definitely. Yes, it is a very, very common misconception.
And the other aspect that you mentioned that I think is really important is that you said that nearly half of payer respondents indicated that current quality measures fail to adequately capture high-risk populations. And I think this is such a great point because the quality measures that we have right now really seem focused on diabetes and getting eye exams yearly, I believe it is, as long as you're a patient with diabetes. But like you said, those patients that don't have diabetes are just left out of the equation in some instances with regard to those quality measures.
Yeah, that is very true. And then, separately, when we're thinking about our patients with the diabetes, there are a host of other challenges there as well. So not to kind of exclude them either.
Yeah, yeah, and I think that's a really important thing to mention that when we have a patient with diabetes and we're talking today about their eyes, it's important to capture that the burden of these injections that you mentioned that leads to decreased persistence. That might not just be because of the burden that these eye injections are causing for them, the travel time to the clinics and whatnot, but all of the other specialists that they also have to see, and then repeated PCP visits and so forth, just to make sure that they are controlling their diabetes as well. So it's not just burden due to this disease area, but just overall, diabetes carries such a heavy burden. But it's not, again, to forget about that patient population with AMD as well. All right, great. Well, Dr. Ali, I'll come back to you with this next question. Where are we with the current prevention and treatment strategies for AMD and DAR DME?
Yeah, so when we think about treatment strategies, clinicians generally do feel that we have effective therapies. So anti-VEGF agents have absolutely transformed these diseases that were blinding conditions into manageable chronic conditions. And so the issue isn't necessarily that our treatments are not effective. It's a variety of issues around delivery, as we've talked about. Certainly, we wouldn't turn down treatments that last longer and decrease the treatment burden, but generally we do think of our treatments as effective, but there are operational considerations otherwise. So when we've asked healthcare providers, the most frequently cited barriers to preventing vision loss really are high patient cost sharing. So there are costs associated with treatments, particularly frequent treatments, lifelong treatments, all of that. There's a cumulative burden. As we've talked about already, transportation and logistical challenges, insurance coverage issues, as well as administrative burden, particularly on the practice side for patients that are sometimes receiving injections 12 times a year, which means every month. So there's quite a lot around what we call and what providers like to talk about a lot, which is treatment burden, and that ongoing efforts to reduce that and or with the hopes of newer and sort of latest treatments really lasting longer and minimizing the treatment burden in a different way. Additionally, healthcare providers have also ranked reducing financial barriers and early identification of at-risk patients as potentially very impactful improvements. There's also concern about screening gaps in primary care. So HCP respondents emphasize lack of patient awareness and, as we've talked about already, an inadequate screening integration as leading contributors to delayed diagnosis. And so from the clinician standpoint, the strategy works, but the system supporting it can be inconsistent and sometimes quite burdensome.
Wow, so it really seems like we can't ignore these statistics that 50% of people are going to be prematurely discontinuing therapy after 2 years or so. And so, if we were to shift from strategy to execution, then what would need to happen first to truly operationalize that alignment?
Yeah, this is an important consideration. And when we think about it, we really think about it operationally. And I think it starts with data sharing and workflow integration. So, for example, if health plans can identify members with diabetes who haven't had a retinal exam and proactively coordinate outreach with primary care practices, that directly would support earlier identification. Secondly, we can think about simplifying authorization at the point of treatment initiation. That would make a really considerable difference. By initiating treatment early, we do know that patients ultimately do better. And that could mean standardizing criteria across lines of business or gold carding high-performing retina practices so we're not repeating the same approvals for chronic therapy. And then thirdly, we can think about something like building structured navigation support. So whether that's through payer-sponsored case managers or embedded referral pathways, that can potentially help keep patients in the practice and maintain adherence. And strategy is important, but operational alignment does come down to shared data, predictable processes, and really clearly defined handoffs between primary care, optometry, ophthalmology, retina specialists, and most importantly, I think the health plan as well.
Yeah, that's very well stated. Thank you. And I think that the traditional view of health plans is that they put prior auths in place and they get in the way and that delays care. But there are so many other resources that they can offer. Like you mentioned, payer-sponsored case managers and embedded referral pathways, for instance. I think these are very realistic, low-hanging fruit for the payers to incorporate into their practice to really improve outcomes, which can, again, save patient vision in the long run potentially. So I think that's really important that we think about that as well. So Julie, I'll come to you for our final question here. If clinicians and payers are aligned around preventing blindness from these diseases, from the patient perspective, how would we know that we're succeeding 5 years from now?
I would say that alignment really means that our coverage policies reflect how these diseases are actually managed in clinical practice, so that screening is built into existing chronic disease programs, and that treatment initiation isn't delayed by avoidable administrative hurdles. And patients can stay on therapy without the financial uncertainty of how much they're going to owe. So I would say 5 years from now, what does success look like? It's higher screening completion rates among patients with diabetes and older adults at risk for AMD. It's fewer patients presenting with advanced vision-threatening disease. It's reduced treatment drop-off over the first 2 years of therapy and measurable improvement in quality metrics tied to retinal care. And I want to add that it's also increased patient satisfaction, provider satisfaction. It's the circle of happiness when patients are well cared for and, persistent with their recommended treatment.
Excellent, thank you. And I think we have an extra minute here, so I want to ask another question. From the work that you do, Julie, are we seeing that these rates are trending in the right direction, or in the I don't want to say that this way, but in the wrong direction?
That is a complex question. I would say, as we know, as I referenced earlier in the program, is that we know that the rates are increasing for diabetic retinopathy and DME and AMD. However, I think that, with AI, there's a lot of promise with technology, and there's a lot of awareness among the healthcare staff of the need to improve the systems and of course, the payer involvement. So with that awareness and just advances that we've been making with technology and AI, I think it's very promising in what we can, achieve together. I do think that, a move towards patient-centered models, such as care coordination or, case management programs, as referenced earlier, paid by payers or community health worker, sort of models are ones that haven't quite been explored yet in the eye care world that I think would be, just really wonderful and could improve the patient outcomes.
Yeah, it really sounds like that would make a meaningful difference. And I want to go back to your point about AI. And from the payer perspective, I think this is certainly an area of interest. I think there is a lot of thought about how AI can be used to improve healthcare. But just thinking about it from the perspective of predictive analytics and identifying patients who might be at risk for complications is an important consideration and an important opportunity, I should say, for payers as well. I think Dr. Ali, you highlighted earlier that if we can identify those patients who aren't doing their retinal screenings as they're supposed to and communicate that efficiently to the retina specialists, to the PCPs, etc., then that's very simple to do. I think that predictive analytics can even take that a step further, right? And identify these patients who might have risk factors and all of that. Now, I'm not, a technical person by nature, but I understand that there is so much more complexity to it, and the amount of information that can be fed into these systems that can produce really meaningful results for patients is incredible. But, are we there yet? I'm not entirely sure, but more and more health plans are turning to predictive analytics to help identify those at-risk patients earlier. So, Dr. Ali, where could payer-provider collaboration focus first to have the greatest impact in preventing blindness from these conditions?
That's a great question. And I would say that there are three potential readily identifiable leverage points. So first, as we've talked about already, early identification. So integrating retinal screening into chronic disease programs could be potentially very productive. Secondly, we can think about something like reducing financial and administrative friction at treatment initiation, so on the practice setting side. And then thirdly, supporting long-term adherence. I think this is a really challenging area, but really supporting through navigation, predictable coverage, and transportation support for our patients. And, what's really interesting and striking is that when we looked at survey stakeholders, they do largely agree on the priorities of expanded screening, improved insurance coverage, and reducing that administrative burden. And those consistently rank near the top across survey groups. That being said, one of the biggest challenges, as we've spoken of, still is treatment burden, and patients often require injections, as I've mentioned, every 4 to 8 weeks in the first year. And we know from the literature that up to 50% of patients do discontinue treatment within 2 years. And so, we do benefit from extended interval or higher dose options of the treatments that we have that safely allow dosing potentially every 12 to 16 weeks and can really meaningfully reduce the visit frequency. And from a patient standpoint, fewer injections may certainly improve adherence and their willingness to come in, and reducing anxiety and logistical strain as well.
Yeah, that's really good insight, and I think really important to consider from the patient perspective is fewer copays for longer injection intervals as well. And then, the payers really want to make sure that they're getting something for the medications that they're covering, right? And if all we're going to see is discontinuation after a few years, then what did we, really pay for when we covered those medications is going to be the question that they're asking. Dr. Ali, do you have any insights as to how patient vision reacts after discontinuation?
Sure. So that's a good question. It certainly varies by disease type. Um, And so the patients that we treat with wet or what we call neovascular age-related macular degeneration or AMD, they are not meant to be off therapy. So discontinuation of therapy kind of, reverts us to a time period 20 plus years ago where patients had bleeding in the dead center part of their retina, dead center part of their vision. They had scarring and then they were permanently blind. And so discontinuation of treatment allows for the possibility of the patients to have what we call a bleed, and that is not really truly reversible. Now, diabetic macular edema is somewhat more forgiving in the sense that the physiologic change is not as catastrophic. However, it is sort of a um, continuous and insidious process of, ischemia to the retinal tissue, that is poor blood flow, and or exudation or leakage of fluid from leaky blood vessels that we know exist in the physiology of diabetes. And so all of those things kind of turn back on once treatment is discontinued.
Well, thank you so much, both of you, for all of your insights. And I'd now like to open the discussion up for Q&A from our audience. And I'll invite our co-presenters onto the screen here. Thank you both for joining. And we do have a few questions from the audience here, and feel free to continue to submit. We have about 8 minutes left to address these questions. So our first question says, frequency of injections seems to be a barrier that may be insurmountable for some patients. Is there any other mode of treatment in the pipeline to address this? I think that's a question for you, Dr. Ali.
Sure. So that is a great question. And certainly over time, the intravitreal anti-VEGF treatments have shown through clinical trials and real world practice that they are lasting a bit longer, but on the order of weeks. And now we're looking towards soon to kind of likely be commercially available in pipeline development, what we call tyrosine kinase inhibitors, which are also injectable drug delivery platforms. And that may give us on the order of months. Of more time between treatment. Again, these are in development. And then also in development are gene therapy modalities for delivering anti-VEGF. And we're looking at those both in an injection form as well as surgically delivered. So there's definitely promise and a lot of exciting options in the pipeline. And I think some are actually sooner than far away, which is very good.
Great. Thanks so much. And in that same vein, how do providers balance clinical guidelines recommending frequent injections with the patient capacity to adhere to those injections?
Sure. That is a good question. And I think there are lots of things we've talked about already about treatment adherence is important. And we've learned over the years many different identifiable risk factors socio-demographically around risks of lost follow-up, both for neovascular AMD as well as the diabetic related eye disease states as well. And so all of these things we're keeping in the back of our mind, but certainly um, at the cornerstone are treatments that would last longer. And
Hmm.
we're implementing those, into our practice every day in terms of those newer anti-VEGF agents.
Yeah, and as additional data comes out, it seems like the intervals are expanding as well, which is very good news. So, um, next question here, how do providers identify and re-engage patients who are lost to follow-up? Is there an opportunity for the payers to provide any additional support here?
Sure. So on the practice side, I would say in practice management, there are many different tools that are available through electronic medical records to help identify patients who are no-shows, who are lost to follow-up, who are due specifically, for example, for an injection treatment, as opposed to an annual visit, perhaps for something else entirely. So
Mhm.
those built-in aspects to our electronic medical records really are quite helpful. Um, I would imagine, and I'd be curious from the rest of the panel, that there may be something existing on the payer side around, for example, patients that claims are being submitted for treatment, and if those claims are discontinued, whether or not there is an opportunity that is automated or something that allows for identifying these folks. I don't know as much about that, but I imagine that things like this may exist.
Yeah, absolutely. And I can add a little bit of color to that as well. I think there's certainly an opportunity. We monitor adherence on the payer side very closely, especially for those medications that are going to be covered by different quality metrics, star ratings, HEDIS measures, etc. But beyond that, it becomes a little bit challenging, and especially in an area like this where there are varying different treatment plans based on the patient's individual needs. Is it an every 4 week, every 8 week, a treat and extend sort of approach that's being used? And so it's akin in some ways to insulin, if you will. It's impossible to monitor adherence exactly because every patient's treatment regimen is going to be a little bit different. And so I will say that generally speaking, because payers have 1,000 fires to put out at any given time, and DRDME and AMD are just a few of the high cost areas that they're paying attention to. It would be lovely if we had all the resources in the world to contribute to monitoring adherence from the payer side. But unfortunately, I think there is certainly more of an opportunity than is being currently tracked right now by payers, generally speaking. I think again there is benefit there, and connecting with patients and all of that. But from the payer side, I think there's just too many other aspects of treatment that are being focused on, and there's only so many population health pharmacists, for instance, to go around and call patients and make those interventions. So more of an opportunity than I think there is action at the moment. There is another question here. Do the injections cause scarring?
So that's a good question as well. So definitely scarring is not something we've seen as related to injections over time, meaning on the surface of the eye where the injection is administered. If I think that's what the question is referring to, we do know that patients, particularly elderly folks or individuals who are very, very nearsighted, whose wall of the eye may be a little bit thin. We know that over time, serial injections in great number can allow for kind of leakage from the eye or just from repeated puncture and things like that. That's very uncommon, but a way to offset that is that providers may kind of rotate the position of where they're administering the injection over time. And this is really talking about patients who are receiving injections over the course of years at a high frequency interval. Again, though, this does really highlight the need for treatments that last longer,
Mhm.
certainly.
Yeah, absolutely. That's really interesting. Thank you for that insight. And Julie, I want to come to you for one last question here as we wrap up. How do language barriers, health literacy, and cultural factors affect the patient journey?
All of them have a huge role to play in, what is retained by the patient and, the adherence. If the information is not delivered in a way that is suitable to their learning style, to, their preferred language, they can't get all of the information they form decisions that impacts the family as well. And I would say I have just two examples to share that really underscore, I think, the importance of the role of language and culture and literacy when it comes to, treatment for AMD and DME and DR, which is There was one patient who she grew up in a multi-generational Muslim home, and they had some real hesitancy to go and seek, care at the hospital or any kind of Western medicine. And she had type 1 diabetes that by the time she got into care, which was the first time she went to the doctor was at 21, she was already blind from diabetes. And so I think this is where when we talk about, integration, somehow this is a very complex problem, of course, because, they're not going into the doctor. But to think about unique and creative outreach models, care coordination, community health workers that could be potentially out in the communities, reaching people who don't know that they're at risk and working, in the preferred language, suitable to the preferred culture, all of that. So, some important, concepts to bring up. And the other one is a woman who had AMD and made the decision to move into a rural area in California. And then it was, her AMD advanced and she was told that she needed to receive injections on a regular basis. And she actually had the resources to move back to the big urban setting. But so many patients don't have that access. And so I think it underscores again the importance of really, this webinar and really thinking to address all of these complex problems.
Wow, yeah, thank you so much. I really appreciate that insight and those examples to wrap us up here. I'm going to go ahead and thank everybody for attending, and thank you to Julie and Dr. Ali for the insightful discussion. And thanks again also to Regeneron for their support for the educational activity we had today. So in order to claim credit for the activity, please click the complete evaluation link in the activity. And once the evaluation is complete and submitted, you'll be able to select the type of credit that you require. You have to claim credit to receive your certificate or for pharmacists to submit to the CPE monitor. If you have any technical issues at all, please email Impact Education at info@impactedu.net. Info@impactedu.net.